Morning. I think it's still just about morning. So for those who don't know me, just to put it in context as to why there is a registrar stood up here, my name is Simon Fleming. I'm the immediate past president of the British Orthopaedic Trainee Association. I work with an organisation called the ATDG, which is like the trainee arm of the Academy of Medical Royal Colleges. I work with the Canadian College around medical education. I'm currently doing a PhD in MedEd, so I kind of like the teaching thing. And I'm going to be talking today about management and ethics. And what I'm not going to do is give you the answers, because I think the answers are really, really boring. It's more about what you have to say and how you say it. And I think that's really how you get ahead in interviews. So I'm going to talk about dealing with ethical dilemmas, which is ironic considering I'm an orthopod. Communication skills. So I can talk about communication skills here, which is really satisfying. So one of my jobs is I sit on something called the Selection Design Committee. So I help design ST3 selection for trauma and orthopedics. And again, as an orthopod, it makes everyone laugh because I help write the ComSkills stations. And it's because it's a real discriminator. So at the moment, hopefully none of you have yet had your first fitness to practice hearing. But when you look at the GMC and fitness to practice hearings, it is generally communication skills and interpersonal skills that happen. Okay, it's not because you've got feet for hands or can't operate. It's because of how you interact with your colleagues and your patients. So they do look very closely at how you communicate. We're going to talk about all this sort of stuff. And again, in a way, I remember going through the process you're going through now. I got really obsessed with the nitty-gritty of this. And often it's not really about the nitty-gritty. It's about how you present yourself and how you answer it. Because by definition, management and ethics, there are not so much right answers as a spectrum of things you can say that show that you are safe, that you are trainable, and that you have paid attention during your training so far. So, learning from mistakes. The classic thing when someone says, tell me about, a mistake you made. You try and make it a strength, and actually that's not what we're looking for. The biggest mistake I make is I just can't stop working. I just can't stop being such a great trainee. My biggest mistake is I care too much. And we all sit there and go, bullshit, right? What's far more useful is actually be honest. I mean, don't be terrifying. There was that guy I killed that one time. But give a mistake you made about when you made a prescribing error. So long as, again, it's not terrifyingly negligent, because we all make mistakes. And actually, it's far more powerful to go, here's a mistake I made, and here's what I learned from it. Because actually that's what's powerful, because the best trainees, the best consultants that we aspire to be like, learn from their mistakes, right? Feedback is the breakfast of champions. So if you can sit there and you can go, I made this error, and it doesn't have to be a huge error, it can be something very small. I picked up the wrong set of patient notes. It happens all the time, right? I forgot to do this bit of work. But then it's far more important to reflect verbally about what you learned from it, why you made the mistake, how you will not do it again, what you took from it. Because that is what they're looking for in the interview. Are you trainable? Are you safe, right? No one's looking for you to go, I once put a cannula in the wrong patient, and so I then did a massive dissertation on it, and I thought, no. I put a cannula in the wrong patient, so because my first concern is always patient safety, I went and I told the patient and I apologized. I documented in the notes, but here's what I learned. I learned that at the time my patient list wasn't really organized enough, and do you see what I mean? That's what they're looking for, because actually as a registrar, I make mistakes all the time, okay? And most of the consultants I aspire to be like, they make mistakes too, and it's about how they learn from them and how they deal from them, and how they grow from them. Coping with pressure. Again, you need to be mindful not to try and pretend like you're invincible, because you're not. You're just not. And actually, coping under pressure, the things we look for are the really common things. I'm organized. It sounds really boring, right? I keep a patient list. I prioritize from life and limb, urgent. And you know what? It is okay to say there's some stuff that can just wait till tomorrow. There's stuff that can be handed over to my colleagues. That's how I cope with that sort of pressure. Equally, you can give examples that are non-professional. This is how I cope if I've had a busy weekend on call. How do you de-stress? How do you come down from the ceiling? Okay? And they can be personal. So they might give you a scenario. You have a busy on call, this is happening, this is happening, this is happening, and this is happening, and your registrar says they're going to theatre, and your boss's phone doesn't have any phone signal, and A&E is saying that there are breaches, but actually if you stop, you go, well, that's just work, isn't it? That's just what you do at your job. So don't give an interview answer, because that rings our bullshit alarms, right? Give a real world answer. Well, regardless of whether A&E are calling me and screaming about breaches, I prioritise my patients in the following way, and I prioritise my life in the following way. And if there's a really sick person on the ward, they are more important than a really well person in A&E. They just are. Okay, because your priority isn't targets, right? Mid-staff's inquiry, don't treat targets, treat patients. And you just need to be honest and authentic. Okay, because again, if you deny that there's pressure in your job, what you'll find is we will go, well, they don't have insight into the specialty. Because the pressure never ends, right? Your bosses aren't at the golf course anymore. They are under far more pressure than you are aware of. So you just need to be open and honest and go, there is pressure, and this is how I deal with it. Be honest, be reflective, and remember to keep patients at the top of your list at all times. But the thing for me that comes right after patient welfare is your welfare. Okay, we're looking for people who are not going to burn out, who are not going to destroy themselves, because equally that's not what we're looking for. You know, no one's going to give you a medal for saying, well, I just work 24/7. You know, if there's not enough coffee, I'll just abuse methamphetamine because, God damn it, I got to get those numbers, right? It's about taking care of your patients and taking care of yourself. The WHO checklist. Know what the WHO checklist is. Know who Atul Gawande is and why we do it, and know all the facts and figures about, oh, you know, it's reduced mortality and morbidity. But actually, there's more to it than that. And again, just be able to talk about it. Talk about your experiences of it. Talk about your role within it. And actually, there is no problem. If you're doing a lump and bump list with me, I might say, well, why don't you do the WHO checklist? If you're doing the operations, you should be the one leading it, right? And talk about why it's important. And you can talk about patient safety again. You can talk about that sort of stuff. But actually, for those of you who've been in the WHO checklist, I think the most powerful thing for me is that what the interview does as well. It makes you verbalize things. So in your head, you might be going, right, well, I'm going to do a carpal tunnel decompression, right? It's a 5-minute operation. When you say out loud, you go, and I'm going to use a tourniquet, and someone goes, oh, you want tourniquet? I didn't. Oh, you never said, oh, I'll go get the tourniquet then, right? So talk about why it's important. Talk about why it matters. Talk about, for example, how you might make it better. Streamline it. So as an example, at the moment, I recently proposed at my last hospital, and we're talking about it, about whether we should talk about training in the WHO checklist. I know some people say, you know, every day is a school day and every case is a training case. Do you not think it would be useful if the anaesthetist said, I'm going to let my registrar do the spinal on this case, so that's going to add an extra half an hour? Have some ideas, have some thoughts about your role in this, because the worst thing you can do is think that the WHO checklist isn't your problem, isn't something you do because the boss does that. Well, no, if you're doing the case, if you're doing the trauma list as the core trainee, which you might be doing, if you're doing that IND, that's your WHO checklist. Never events. Again, know what a never event is. One of the biggest things about never events, of course, is that they should never happen. By definition, they are wholly preventable. Ideally, have a couple of examples in your head, either of ones you've witnessed or heard about or been involved in, and it does happen. But more about that, talk about, again, how you might reduce them. Because, again, your focus is patient safety. So if we give you a scenario, how might you deal with it at different stages? What would you do if your consultant you thought was about to operate on the wrong limb? It happens. We know it happens, which is why never events and the systems in place happens. You've got to remember that the one down from never event is near misses. That is, everything about a never event, a wholly preventable blah, 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 just no patient harm occurs. So that means you've gotten to the point where the consultant has got that scalpel out and they're about to do it before someone goes, just boss, the other thing, right? Because it does happen. And you need to be able to talk about it, and you need to be able to talk about how you are going to be an advocate for your patients, how you are going to protect your patients in the face of increasing pressure and being in a rush, how you might record a never event, report a never event. What duty do you have? Who should you tell if you make that first skin incision and then go, oh, it was arm, not leg? Because it does happen, because I've been in the room when it's happened, and you go, oh, And you have to have an idea about what you would do about that. Who would you tell about that? Whose responsibility is it, in fact? You know, oh, well, never mind, Prof, we took out the wrong kidney, but you're gonna fill out that Datex, right? No. Okay? So be able to talk about what you would do. And sometimes they all sound more rock and rolly, but again, incorrect drugs given to patients, right? Is their patient on a beta blocker? No, was it Miss Smith or Mrs. Smith who was on insulin? Ooh. So just be able to talk about it again. Clinical governance is boring. It's really, really boring, but they do have to ask about it. So my advice would be, because I find the definition really difficult, know the 7 pillars, and there's a really boring mnemonic. This is my spiel, and well, don't all plagiarize it, because then they'll be like, oh, everyone's heard Fleming speak. But what I would do is I would make it about you as a candidate. So my generic interview answer, and again, rehearse it so that it sounds not rehearsed, is clinical governance is a framework by which we in the NHS try and improve our patient care. There are 7 pillars, but the ones that I am most involved in are. And then just list the things in your portfolio you want to talk about. So for me, I go, the ones I'm most involved in are clinical care, and then I talk about the jobs I've done. Research, I talk about the papers and presentations I have. And education, I talk about my med ed stuff. And because they don't want to hear 500 people list the 7 pillars of clinical governance, because it's really dull. So instead, talk about why we should give a damn about clinical governance. And the point is, if you've got an awesome audit that you took to the ASIC conference and you presented it, won a prize, then say, well, you know what? The pillars I'm most involved in are audit. Audit is where, we look at this, and actually one that I'm most proud of is this. And for example, if your 2 things you're most proud of are audit and research, have a way of talking about it that makes me, as an interviewer, care. So I had a candidate once say, the difference between audit and research is one is, what song are we singing? And the other one is, are we singing the song right? And I was like, well, that's just inspired. That's genius. And then he went, and actually, here's an audit I've done, here's a research piece I've done, and they're both on the same topic, but they're very different. Well, that would have been, if he'd broken into song, I'd have been far more impressed. But you see what I mean? Because actually, anyone can buy that white book, the interview book, and just learn it cover to cover. But that doesn't tell me that you're going to be a good colleague. It tells me that you can read a book. Have something to say about clinical governance rather than knowing the definitions. Because otherwise it is just as Prof said, what's clinical governance? There are 7 pillars which are, I've seen people get their fingers out and they count them off their fingers, and it's like, well done. There will be a Q&A. I'm happy to answer any questions, and best of luck.